Thank you, Barbara. Good morning, everybody. How is everybody? Good? Let's hear it. Good. So Barbara and Russ have been awesome in helping create this today. You said it was last year that we did the summit. It was actually this year.
Was it? Oh,
It was in February, so it seems like a long time. And originally both Dr. Rodriguez and Dr. Bennett said, we need to do something for the community, right? And let's do a summit. Let's start something small. Originally, we didn't know how many people would show up. So we kind of planned the first one in February in Orlando. We thought maybe 50 people would show up, 40, cross our fingers. So 175 people registered for that one. And we kind of like this one, we had to stop at, this one we stopped at what, 250? Because people were still, registered. So there's a need for this, right? So we started the one, in February, very small. This one, even bigger. Hopefully we can continue doing this in the years to come, thanks to the sponsors. And that's why we do the signing of the papers, because we truly need for you to engage with them and learn about them, because they are helping us do this for you, because obviously everything here costs. So they are the ones, and we want to do it free for everybody. So please talk to them, hear them, what they have to offer, and they have some cool pens and stuff as well. So Barbara is so organized, and Russ, I think I've told this a couple of people already. I've spoken to them more than I've spoken to my wife the last couple months doing this. They have been great in organizing this. Barbara even wrote a speech for me that I'm not following right now, and it's here, because she said 3/4 of it already. So she already said it, so I don't have that much to say about that other than the sponsors. But I'm going to also introduce Dr. Rodriguez, who is a dear friend of mine and my boss as well. Dr. Rodriguez spent the majority of his career, a decade and a half, at Gainesville UF, and then at the VA in Orlando. And him and Dr. Benez decided 5 years ago to do this, to create Neurology One, which is a comprehensive center for neurologists fellowship trained in movement and cognitive disorders, or in other disorders as well. So he said not to say that much about him, because his CV is like 100 pages long. But without anything else, Dr. Rodriguez.
Thank you. All righty. I am very excited to be here. I am very excited to see this room full of people. This is just amazing. This is wonderful. For us as physicians, as your doctors, we want to share the knowledge that we have, and seeing the support of the community for us is very important. And, I'm just going to tell you a couple of things before I begin my talk. And, it's about the last week. The last 2 weeks, actually, have been very stressful. I haven't been able to sleep well. And Jennifer, who's there, my wife, right? Jennifer, raise your hand there. So she's like, what's wrong with you, right? What is wrong? And obviously, I was a little bit anxious about this event. I wanted to make sure that everything went well. But my New York Mets were eliminated from the World Series. Has been very difficult. Has been very difficult. But then at the end, I was quite excited that the Yankees and the Dodgers made it to the World Series, right? And, this is going to provide for phenomenal entertainment over the next week. And did you guys watch the game last night? Yeah. So because of the game last night, I just need to show you something. So, most of you know that I love fishing. but I love baseball at the same time, okay? And when I saw Freddie Freeman hitting that home run last night, you know, something came to my mind about what is going to happen today, right? And with all of us here, now we're going to be swinging for the fences, right? And we're going to be taking care of Parkinson's disease. And we're going to grab a bat and we're going to hit Parkinson's in the head. We're going to hit it on the side. We're going to give it an elbow, right? Why? Because there's a lot of hope. I think that we're making great progress when it comes to the care of people with Parkinson's disease. There's a lot of research going on at the same time. And then looking at all these sponsors, you know that there's a lot of people backing you up, okay? So with that, let's get to our presentation. Jennifer, remind me the bat. Alrighty, so today, you know what? I don't have a screen here that I can see what I am presenting. But let's see. Yeah, so I'm just gonna go down there. So today, I'm going to be speaking about what are the new treatments that are available for people with Parkinson's disease, what is new and what is coming, right? And I'm going to be speaking about medicines that were just approved recently. And then I'm going to tell you about medicines that are sitting on someone's desk at the FDA waiting for the stamp. And then I'm going to tell you about the other ones that are in the process of being submitted to the FDA. So we're going to talk about that. I'll explain to you what that is. Then at the end, I'm going to talk about some of the advances that we have seen in deep brain stimulation. Okay, that's the surgery for Parkinson's disease. A lot of people are scared about it, but I'll try to simplify and demystify what deep brain stimulation is. So we all know that Parkinson's disease is a chronic neurological disorder, and there's about 1.5 million people with Parkinson's disease in the United States. Did you know that one person is diagnosed with Parkinson's every 6 seconds in this country? Okay? So there's a lot of people with Parkinson's disease. And something that I like to mention people, because as you are in this room, you might be looking at each other and you see that not everybody with Parkinson's disease looks the same. Because there are 3 types of Parkinson's disease. The one that we call tremor predominant. That's the shaky type. There is one that we call the akinetic rigid. So what that means is slow and stiff. And then the other one is called the postural instability and gait abnormality. That's about 10% of the people with Parkinson's, and those guys, I carry them in my heart because they are falling down and they're having trouble walking from the beginning. That is the worst type of Parkinson's disease, right? But you know what? You know, some of these patients, they're getting the short stick, but be aware that we're right behind you and we're going to help you. We'll try to do everything we can. And when we speak about Parkinson's disease, I want you to see this slide because this is the take-home message for you today. We'll be talking about new stuff, but I want you guys to understand why some things happen. So when we speak about Parkinson's, we're speaking about motor symptoms. Motor symptoms is everything related to the movement, the tremors, the stiffness, the slowness, right? But what happens is that after people have Parkinson's disease for quite some time, they develop what we call the non-motor symptoms. And here we're speaking about depression, constipation, certain balance issues, right? And this is what I want you to understand. It takes about 6 years. You know, 6 years is that line where during the first 6 years, tremor, stiffness, slowness predominates in the condition. And then after 6 years, the depression, the apathy, people feeling different about being with other people. And many times, you know, the significant others come to the clinic like, doctor, what can I do about this, right? You know, and we give them coffee, you know, we try to stimulate them, we go to events. And this is very important because socializing, you know, this brings the good hormones in your brain for you to feel a little bit better, but this might motivate some people. But those non-motor symptoms are extremely challenging. I even have a patient. Actually, he is from the Brevard area. And this man, he actually looks really good from the Parkinson disease. You know, the tremors are controlled, he's walking fine, he's not falling, but he's very depressed. And it doesn't matter what I ask him, the depression takes over every answer. So it doesn't fit what we see physically from the way that the patient feels. So it's very challenging. Be aware of that, okay? Motor and non-motor symptoms, and it's about 6 years when that difference comes. So we're going to be speaking about how is it that we diagnose Parkinson's disease, and I'm going to take a quick minute here for us to understand because there is a new test that was recently approved. So many of us know about the DAT scan, right? And the DAT scan is the brain image that is done for Parkinson's disease. And the main indication of the DAT scan is to help us differentiate essential tremors from Parkinson's disease. But a positive DAT scan does not mean that you have Parkinson's disease. Do you hear that? A positive DAT scan does not mean that you have Parkinson's. What that means is that you have a disorder of dopamine dysfunction in your brain. From there, you need to go see your doctor and go a little bit deeper to try to figure out what that positive DAT scan really means. Now we have a new test, and that test is called the SIN-1 test, okay? And the SIN-1 test is a skin biopsy that we do, a very tiny biopsy close to the ankle, close to the knee, and in the back. Takes me 5 to 10 minutes to do one of these, very easy. We put a little bit of lidocaine, and then we have a tool. I'm gonna put a video later about this SIN-1 test for you guys to see how that looks. And this team from Harvard, what they found was that their normal protein that is typically associated with Parkinson's seems to be in the skin as well. So their patent, their magic is that they have the dye, they have the way to find it. And many times that is helpful because as you have heard about Parkinson's disease, you probably have heard about Parkinsonism, which is stuff that looks like Parkinson's, but it's not Parkinson's disease. And frequently, that skin biopsy will help us determine what is going on, okay? And that skin biopsy can be positive 5 to 10 years before a person is diagnosed with Parkinson's disease. So what that means is that this stuff is progressing in your body and until eventually the symptoms begin to show up. So how do we make a diagnosis of Parkinson's disease? You have to go see the doctor. We take a picture of the brain, we do a physical examination, we have to listen to you, we try to put everything together, and finally we can say that you have Parkinson's disease. So these new tests that we have, like the DAT scan and the SIN-1 test, they are very helpful, but they are not 100% sensitive. They will not tell you 100% if you have Parkinson's disease. All right? Were you there? All right, let's continue. So let's talk about recently approved therapies. And I'm very excited about this one because just like Eduardo said earlier, we did this program in Orlando in February, and I talked about stuff that was coming. So this stuff is already here. And it took a lot of time. Listen, it was sitting on someone's desk at the FDA before it finally got approved. So the first one that I'm going to talk about is called Crexont. Crexont is a formulation of carbidopa-levodopa. And let me tell you, what is different about Crexont from the regular carbidopa-levodopa, the yellow pills that we have already. So what happens, for those of you that don't know, levodopa, which is the active ingredient, is a naturally occurring amino acid. If you eat a cup of fava beans, you have as much levodopa as 1 tablet of carbidopa-levodopa 25-100. Okay? What happens is that levodopa has a difficult time getting into the brain, so it needs help. And that's where the carbidopa comes. From that 100 milligrams of levodopa that you take in 1 pill, you know how much gets inside the brain? Only 5. So there's a trek, right, to try to get to the brain and being able to provide the benefits. And the challenge that we have is that the half-life, the duration of that medication is about 90 minutes. So your brain will store some of this, will try to give you some benefit later, but the problem is that as Parkinson advances, we need a longer duration of the medicine So that's where Crexon comes. So initially, we had a medication called Rytary, try to fill that gap, which was a phenomenal option, but Crexon, we believe, is even better. It's longer acting, and many people taking Crexon might need to take medicine only twice a day, the most 3 times per day. And we have people, I actually had a guy a patient from Brevard, that he was taking carbidopa, levodopa every hour on the hour. For somebody like him, this is a big difference, right? Because he was leaving just watching at the clock just to take the next dose of the medication, so these kind of products might be able to help them, okay? So it's a long-acting carbidopa, levodopa. They just have this extended release formulation that really makes this very useful, okay? We're gonna make this available as well for you guys later. So I'm just gonna move a little bit faster, okay? So the next one is Vyalev, right? In the previous meeting, I spoke about Vyalev as a possible option. And Vyalev, actually, Crexon was approved about a month ago, and Vyalev was approved like a week ago, right? 7 to 10 days ago. And Vyalev now is an infusion of carbidopa, levodopa. And many people knew about Duopa, where we had to put the tube in the stomach. But for this one, you don't need to have a tube in the stomach. We put a patch in the skin. And I don't know if you have seen those insulin pumps, right? So it is fairly similar. And one of the things that people are concerned about is, how big are these pumps, how this is going to work. So obviously, we're going to train people about it. But for you guys to have an idea, this is the pump. This is how the pump looks. This is it, okay? So you see that I can carry it here in my jacket pocket. So it's not that big, It's the size of maybe 1.5 or 2 iPhones put together. We already carry one, so we'll have something else, right? And the goal of these therapies is that they will give you medicine 24 hours a day, just around the clock. Just imagine going to bed and not having to take more medicines, and the medicine is working, and you waking up in the morning, and you are already in the on-medication state. Phenomenal, right? Phenomenal. So just like everything, it's not going to be a treatment for everybody, but this is a phenomenal alternative. Sometimes we have our DBS guys here that are not considered good candidates for DBS, so this might be a phenomenal option for them, right? And I do believe that it's even a better option for people that already have DBS. They find the medicine is not working as well with the DBS, and adding something like this might be the solution for them. So now that is coming, we're going to be hearing more about it, okay? Let's see. Medicines approved in the last 5 years. So this is, I'm just gonna go really quick over these ones because many patients come to the clinic and they don't know that these medicines are available. So this stuff, we can get it today, right? So number 1 is Imbrilla, right? Imbrilla is an inhaled form of carbidopa, levodopa. So let's say that you are at a wedding, you turn off, so that means that the medication stopped working. You pull this Imbrilla, you inhale it, and in a matter of 5 minutes, it's working. You're back on. And it's good for about an hour, so it gives you an opportunity to take your medicine. But here you have an opportunity to help with those off episodes a little bit more efficiently. Xadago is a monoamine oxidase inhibitor. It has been around for about 5 years. It's a supportive medication to carbidopa, levodopa. So we use these medicines for people where if the carbidopa, levodopa is not lasting enough, this one will help fill that gap. What I like from Xadago is that it is a once-a-day medicine, right? The issue is that while it is good, it is like it's a single, right? In baseball terms, it is a single. It's not a double, it's not a triple, so it's not that powerful, but it is good. It is good, and it helps, and it's a good option for some people. The same thing for Neurians. What I like from Neurians is that it is a new class of medicines to treat people with Parkinson's disease. So historically, we have been thinking about dopaminergics and dopamine stimulation. Now we have medicines that are trying to address other circuits in the brain to help people with Parkinson's disease. And then Ongentys is the other medication. This is a medication that was approved in Europe in 2016, gets approved in the United States around October of 2020. And what was happening in October of 2020? We had the virus, right? So We didn't talk about this. There wasn't a lot of information. The company, the FDA approved it, and it was just sitting in the drug company's desk because there was no way to market it, right? So now there's a little bit of a hype trying to bring it back because I have to say that the drug is quite powerful. So it is a good medication, once again, for people that are wearing off, that they feel that the carbidopa, levodopa is not lasting enough. Now, be aware that people that have a little bit of dyskinesias, those extra movements, they might get worse on this medication. So your doctor might need to adjust your medicines. Gocovri, however, is another medication approved maybe within 5 to 6 years. It's a medication used to treat dyskinesias. It is the only FDA-approved medication to treat dyskinesias. Dyskinesias are the extra movement. Have you seen Michael J. Fox on the documentary, right? So he has a lot of dyskinesia, so a medication like Gocovri might be able to help him always make sure, these medications, some of them have some side effects. This one can have hallucinations and can make the blood pressure go down a little bit. So just be aware of that. I'm just letting you know this for you to have that, take that into account, okay? So medicines expecting imminent approval, right? So let's go over them. So because these medicines are not approved yet, they don't have a name. So this one is called ND0612. And ND0612, I mentioned you earlier the Violev, right, the pump. So ND0612 is a pump as well of carbidopa, levodopa. But it's a little bit of a different molecule. So the Violev formulation is called foscarbidopa, foslevodopa. It is a pro-drug. And because of that, they can administer higher dose of the medication. That's why many people can go 24 hours a day, and it might be the only therapy that they need. They might not need to take another medicines. These ND0612 are for people that will be on the carbidopa, levodopa 24 hours a day, but they might need a little bit, they will need some carbidopa, levodopa orally to help it because the dose is not that high. So we're going to have to find that, right? People ask me, so which one is better? I don't know which one is better. We're going to have to start trying them and having some experience with it so we can speak about them, right? To me, the question of which one is better is, that doesn't make sense a lot as a physician because I see always a lot of people with advanced Parkinson's disease. So to me, having the option that I can do something about it is what matters. And then we have a drug called, it's a subcutaneous apomorphine pump. And apomorphine is a very powerful drug. It has been around for many, 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 many years. And it has been available as an injectable. And I don't know if any of you ever tried Apoquin and found the medication to be useful. But the good thing about this Apoquin is that it can help people turn on right away. It is very useful. It is very potent. And in this one, we'll have, once again, an infusion that will be available all day long, okay? So there are some exciting molecules that are being studied right now. One of them is called CVN424. Once again, this is research, so the name, they don't have a name yet. And the great thing about CVN is that this is not a dopaminergic medication. I'm going to explain to you something really quick. In the brain, we have two circuits. One of them is the gas pedal, and the other one is the brake pedal. All of the medicine for Parkinson's disease, they push the gas pedal. CVN424 is the first one to release the brake pedal. So if I can release the brake pedal, then I might not need to add that much carbidopa, levodopa, and these other medications with the potential side effects and the potential for hallucinations, delusions, and so on that could happen with some of these medicines. So this can actually help even extend the life and how people are responding to Parkinson's disease. So this one is one that there's a lot of excitement right about this one, okay? So this one is in clinical trials right now, actually. And then the other one is lenrispodun. That's a tough name for me even. And lenrispodun is a medication that can help smooth out the way that you're doing during your day with the symptoms of Parkinson's with a once-a-day pill that is very well tolerated. And it should not make the dyskinesias worse or anything like that. So that's the beauty. All these medicines that are coming, what they're trying to do is help you have a nicer and easier day. NEU 411 Just a quick comment about it. I just added this because this is what is coming next. The next thing is precision medicine in Parkinson's disease. And what that means is now we're going to start looking into your genes. And depending on how your genes look, we will address what medicines will work better for you. And by doing that, we believe that we have medicine that might be able to slow down the progression of Parkinson's disease because we are addressing now what is happening in the genes. So this is all very exciting. And a lot of you will be able to get tested if you guys want to be tested to look into this kind of products, okay? We have some digital biomarkers, medication. This is actually a watch. It's like an Apple Watch. It's a smartwatch to help us address the progression of Parkinson's disease. And this is very important because in someone's lab, there is a drug that we believe might help slow down Parkinson's by removing the abnormal brain protein. But the FDA says, you need to show me how that the drug is working, and we don't have a way. You know, when we look into prostate cancer or diabetes, we have blood testing, right? But we don't have a blood test for Parkinson's, and that's the challenge, so we're looking into one of these devices, okay? There are some external devices. We have some of them in our office as well. This one, you know, the one on the left is for tremors. The other one is to help people move better. So it's a product from the United Kingdom, the Neurotech one. And this one might be coming very soon for people to purchase it and try it, okay? So I'm already asking for some samples because I want my patients to give it a try, okay? So, surgical advances in Parkinson's disease, right? I'm gonna call Dr. Lago here because I want him to help me here. But when we speak about deep brain stimulation, there's a couple of new stuff that is happening. But before we go to DBS, Dr. Lago, please come here, Dr. Lago. We need to understand how DBS works and who's a good candidate for DBS. So I'm gonna have Dr. Lago because he helps me with this every day. How, you know, what is it that happens? So with this one, you pass it on and explain to them. Yes.
Thank you, Dr. Rodriguez. So with the DBS here, I have a few slides here on who would be a good candidate for the DBS. The DBS stands for the deep brain stimulation. So we have the patients with essential tremors. So in addition to Parkinson's, some patients with essential tremors, we have 4 different medications. Oh, can you hear me okay? Sorry.
Yeah.
All right. So there's 4 different medications we usually like to try for essential tremors, but if patients can't take those medications or contraindicated, or if they don't have a good response to those medications, then we can consider DBS in those essential tremor patients. Now with Parkinson's, of course, we have a lot of Parkinson's patients that we have the DBS for as well. And with those patients, we want to see that they have a good response to the levodopa. So we'll typically do an on-off evaluation in the clinic where the patient would come off the medications. We do an evaluation, then we have the patients take the medication, and then we repeat that evaluation to see if they had a good response to it. Now, we want to see that they have, to be a good DBS candidate, the persistent tremor, usually at least 2 hours or more per day, that they're having the off time there and not a good response to the medications. To be a surgical candidate, we want to evaluate the MRI of the brain. We'll do an EEG. Sorry, is that better? Okay. So we'll do an MRI of the brain. We'll also do the EEG testing and lab testing just to identify any abnormalities that might preclude the patient from a DBS surgery. Now, if there's other contraindications, such as the patients are on blood thinners, they have cardiovascular conditions, or any other contraindications that would preclude them, we obviously wouldn't consider the DBS. We want to make sure the patients have a supportive caregiver that's able to operate the DBS remote there, or if the patient's able to operate it themselves. Finally, so with the good response to the therapy there, the medications via the on-off testing, we want to see the DBS. It could have benefits for the tremors, dyskinesias, even if we optimize the oral and topical medications that were mentioned there, the DBS can still provide additional benefits in that regard. Finally, we want to make sure the patients have intact cognition. So we'll usually do what's called a MoCA test, the Montreal Cognitive Assessment, and we'll also usually do a neuropsychological evaluation to make sure that doesn't identify any abnormalities that would also could preclude a patient from DBS surgery. With the DBS, There's 3 different targets that we can use, and it depends on the scores with a neuropsych evaluation, MOCA testing, if the patient's, which target we might want to use. With the SDN, usually we can reduce the medications by about 60% or more, but if they don't perform well cognitively on some of the testing, then we can look at some of the other potential targets as well for the DBS. All right, thank you.
So Dr. Lago is going to be here with us to answer questions. So Dr. Lago is one of our nurse practitioners, by the way. I was supposed to introduce him. And Dr. Lago has been with us almost over 3 years now, right? And I've been teaching him everything I know. And he has been able to catch everything except the accent. So I'm trying. Someday he's going to come with the accent as well. But yeah, so I wanted you guys to understand who's a good candidate for deep brain stimulation, because not everybody's a good candidate, and I want you to hear how is it that our thinking goes when we determine if a person is a good candidate. So I'll have you just hang around here in case there's any question in a little bit. So let's move on so we can finish soon. What are the advances in deep brain stimulation, right? So this is just, listen, this is turning around crazy now because the devices are getting smaller, they're getting smarter, and this stuff is thinking inside your brain. So when your symptoms get even worse, these devices might be able to adapt. So one of the things that we have advanced, I want to show you this. Not yet. So I want you guys to see how a deep brain stimulation device looked a few years ago, okay? Just look at it. It looks like a pacemaker, you know. You put the thing in the chest, and it's able to stimulate your brain, and that's our job. We make sure that you get the right stimulation. So I want you guys to take a look at this, but now how these devices are looking now, right? So look at the difference between one and the other. Let me put it side by side. Look at that. You know, very small footprint. One of these devices can stimulate both sides of the brain, okay? And then I have another one here. We have multiple brands. We have the Medtronic team. We have the Abbott team that is right outside. We have the Boston Scientific. So they all look a little bit different, and they all have something that is a little bit different. Nonetheless, it is a lot better than what we had 4 years ago. 4 years ago. I was trained in deep brain stimulation in 2004, 2005. And back in the day, we dream about this kind of technology, right? So once again, to me, in my lifetime as a physician, to see that these things are happening, I just never thought that we were able to have something like this with, you know, so much package for every person. You know, these batteries now, they can last, you know, 7, 10, 15 years, right? And that's approved by the FDA in the United States. In Europe, the same devices are approved, some of them for even longer. So I want you guys to be aware of this because, you know, people are concerned, I'm going to have a device that is going to be popping out of my chest or something. Just look at them and just go to the tables. You will see them there. You can take them in your hands, okay? MR focus ultrasound. Let me see. There you go. MR focus ultrasound. Have you guys heard about MR focus ultrasound, the beam to the brain? So I'm not a fan of MR focus ultrasound for Parkinson's disease. Some people will benefit, but MR focus ultrasound right now is only good for tremors. But I told you earlier in those first slides that Parkinson's is about stiffness, slowness, unbalance issues, about the medicine. So I do believe that MR focus ultrasound might be an option for some people with tremors that are not improving with any medicines. But other than that, I wouldn't do it. Not yet. Maybe in the future we will know, we will have more information, but not yet. So that's it. You know, there's a lot of stuff going on in Parkinson's disease right now. There is a lot of research. We're trying to move around and make our connection and develop our network so we can bring all this technology to you people. You know, we work with the universities as well. You know, I spent 15 years at the University of Florida. I still collaborate with them. And every time there's some new technology, we try to make it available to the people here in Orlando and the Central Florida area. So a lot of the things we have them available as well, right? So I want you guys to be aware of this. And what we're going to do, so that in the interest of time, so we can move forward and stay on time, I'm going to be around, and we're going to have some Q&A sessions a little bit later. I don't know if we have any time now, but if we don't, I'll be around. So I'm not going anywhere, okay? I'll be here. I'll stay with you guys. And I want to make sure that we answer every questions you have for you. Thank you.